Good evening. Thank you, everyone. Welcome to the MyCP webinar series. Tonight, we're excited to be able to have Dr. Shruti Thomas talk about surgical spasticity management for children with cerebral palsy who are not ambulatory. My name is Paul Gross. I'm the chairman and founder of CPRN, the Cerebral Palsy Research Network. And I will introduce Dr. Thomas in a little bit. I want to just start out just to give you the agenda. So we always start out with a quick sort of 5-minute update on CPRN and MyCP, so you have some context. We have lots of new people joining, so it's always good to sort of provide that context. And then I'll very quickly turn it over to Dr. Thomas to talk about surgical spasticity management in this population, and then we'll open the floor for Q&A. So we'll talk about that when we get there, but anybody can feel free to ask questions or to type them into the chat. Okay, still admitting people, so pardon me. Okay, so the Cerebral Palsy Research Network's mission is, well, pardon me one sec. I'm going to go and mute everyone but myself just to make life easier. So, and I don't have a mouse cursor, which is always challenging. Okay. So Shruti, when it comes time for you to speak, you're going to need to unmute yourself. Okay, so the mission of the CPRN is to improve outcomes that people with cerebral palsy value most through high quality clinical research and quality improvement initiatives. The people with cerebral palsy value most is underlined because at our start, we actually put together a program called Research CP to set a patient-centered research agenda, and numerous people who are on the call participated in that, including Dr. Thomas. I'll talk about that when I introduce her. So CPRN can be difficult to wrap one's head around, so I'm going to just give a quick definition. So it's a collaborative network of hospitals, institutions, universities, clinicians that work in those hospitals, therapists, researchers, and patient advocates, people within the community that care about research, just working together to improve outcomes through these two tactics of conducting clinical research and through doing quality improvement, both of which are mechanisms to improve outcomes for people with CP. Physically, it's really, other than that collaboration, it's a data coordinating center that's hosted at the University of Utah in our Department of Population Health Sciences. And we really provide a forum for people to come together, to work together, to accelerate research, and provide some tools to help facilitate that research. The main tool that we have created is a registry, and there are two registries. The clinical registry, which is basically a database of people with CP that characterizes them based on their visits to the clinic or to the hospital or for interventions that they have, and captures many patient characteristics, intervention characteristics, and outcomes. Anything from clinical outcomes like measurements of spasticity to functional outcomes like how well someone gets around in the community. And it is built into the electronic medical record system. So when you're interacting with a physician that's a CPRN site and they're typing at their computer as they're interacting with you, that information is going into a form, which becomes data that goes into the registry, and then we're able to use that for research. The second piece is a community registry, which allows us to reach out to anyone regardless of whether or not they're visiting a CPRN clinic, or so when they're anywhere in the community, and allows them to participate in research through surveys that you can take on your phone or on a computer. And it allows us to follow people long-term, which is really, really important to be able to get a sense of long-term outcomes. So MyCP is really it's a web property owned by CPRN that provides access to this community registry. That's its primary function in the form of surveys. And so you go and you sign up there, you can participate in, there's a private discussion forum where many clinicians and researchers are there to interact with people in the community that are interested in research, are interested in sharing their lived experience to improve research questions. And so that's a really valuable function of MyCP. It's also a place where we provide updated news for CPRN studies. We're starting slowly but surely to build out a set of tools that you can take with you or use to sort of prepare for going to see a clinician about your CP and help guide you through that process. So anyone can sign up through mycp.org. So that's MyCP. So this represents our study pipeline. So CPRN was created a little over 5 years ago to really accelerate clinical research. And so the wide end of the funnel at the left is where we're just sort of thinking about ideas and generating concepts. And then those concepts go through a review with the investigator committee, which is all the site investigators that are involved in CPRN. And then it can proceed towards an application. It gets an approval from an institutional review board, which just keeps track of ethics for human subjects research. And then it starts to get implemented and get studied. And then we produce results in the form of manuscripts that then become publications. And then ideally, as we become what's called a learning health network, we take that learning from that evidence and we feed it back into the treatment process. So that's what our pipeline looks like. And you can see we've got a lot of studies in progress. We've had a few publications, got more under development, many ongoing studies. And you can see Dr. Thomas's study right here on spasticity management in children who are non-ambulatory, that is been reviewed as a concept. She's actually working through an application and has applied in some areas and been funded in some areas. She's going to talk all about that. And so we are really excited for you to be able to hear about that and help us move that along to the implementation phase. CPRN is spread at sites all across North America. The green dots represent sites that are engaged in collecting some or all patient data for patients that have CP. The yellow ones are working through preparing the registry. There's a fair amount of information technology involved in that. The red ones are ones that are really just trying to do the compliance, getting ethics approvals to support the registry. And the blue ones, I see Detroit is still blue. I need to change that to now to a yellow. They've joined us at Children's Hospital in Michigan. The blue ones represent sites that intend to join, and they've been making the steps to join CPRN. So before I turn it over to Dr. Thomas, I want to just tell you a little bit about her. She's an assistant professor at Baylor College of Medicine in Houston, Texas. She's a pediatric phys med doc, or physical medicine and rehabilitation, or physiatrist at Texas Children's Hospital. She's the director of their intrathecal baclofen pump program. So she's really right in the middle of this core topic. I met Shruti because she participated in Research CP when we kicked it off in 2017. And she came to the meeting, and she has a PhD that is in sort of basic science. And so we were really excited with Shruti's energy to get her very excited about more clinical research. And she and I actually interacted a couple of years ago, and I said, well, I'm doing this research looking at spasticity management, but I can't focus on the whole population, and I'm going to do it focused on kids that are ambulatory. Do you know of anybody that would be interested in doing this for kids that are non-ambulatory? And she said, I think I might be interested in that. And she's really taken the ball and run with it. Not that I'm big on football analogies, but that's what just came out of my mouth. We were so excited about Sruti's energy and work and commitment that we sort of designed a mentorship program, and she is our original first mentee. So she's mentored by Dr. Ed Hurwitz, a chairman of chairman of physical medicine at University of Michigan. So with that, I'm going to turn it over to you. Shruti, I assume you can unmute yourself. If you can't, let me know. Yep, you can. And I'll stop the share so you can take over.
All right. Well, thank you so much for that wonderful introduction. And yes, I met Paul at a very fortuitous time in my career. Give me 1 second to go into presentation mode here. There we go. Um, Back when I was a resident, and I had early on in my residency, I did a combined residency in pediatrics and physical medicine and rehabilitation at Children's Hospital of Colorado in Denver. And early on, I'd become very interested in adult outcomes and really trying to tailor our care in the pediatric setting so that what we're doing with our children as patients is actually making a difference in adults. And I came across CPRN and Research CP at the right time to get involved with the Research CP workshop and met all of these wonderful people who could mentor and collaborate with me. So I was super thrilled. And unbeknownst to Paul, I had interactions with some individuals that you'll hear about, one of them in this study, which ended up being an inspiration to really work on the GMFCS4-5 population, the non-ambulatory kiddos with CP. And then it just fit right in with my background in neuroscience to be looking at tone management. So we'll dive right in. And I have to say, it is a great pleasure and honor for me to be presenting at MyCP specifically because so many of our talks are to our fellow clinicians, and it's very rare for me to have an audience where I'm really focusing on patients, families, and caregivers. And I would love to have all of your thoughts and all of your questions at the end. So we'll talk about what inspired me to get into this line of research. I'll do a brief discussion of spasticity and dystonia, which if you've listened to some other MyCP webinars, you probably have some exposure to and from your personal experience as well. And then we'll talk in more depth about intrathecal baclofen and rhizotomy, the two main neurosurgical interventions that we use for tone management, that's for severe tone. And then we'll dive into my area of research before we get to the Q&A. So when I was in my last year of training at University of Colorado, I had this wonderful patient who was a 24-year-old female who was super spunky and full of life. And she came into our appointment and, she had pretty severe CP. She was mixed in that she had spasticity and dystonia. She was quadriparetic, meaning that she was weak in her arms and her legs. And she fit into the gross motor classification scale of 4, meaning that she was able to do some stand pivot transfers. She was able to crawl around in her home, but she was not able to ambulate independently. So she primarily depended on a power chair when she was outside of the house. But otherwise, she was really successful. She lived with her parents, but she had completed college. She was working at a local bakery, and she was super excited to tell us about a man that she was dating who also had CP. And I won't lie, we spent most of the appointment gossiping about this gentleman. But then she got to the crux of the problem. And it was that she was starting to have more difficulty with her legs scissoring. So scissoring, if you're not familiar with that term, is that you have increased muscle tone in your hip adductors. So your legs are actually physically crossing. And that was getting in the way of her being able to perform hygiene tasks. And it was also making it difficult for her to position in her chair. So overall, she was less comfortable in her power chair and she was having more pain. Otherwise, she was really healthy. So she had lots of questions for us, like, what do I do? Because I've used oral medications for tone management before. It really was like spitting in the wind and it did nothing. And there had been times where she was on it, times where she wasn't. She was a now young adult. I was about to call her a kid, but a young adult who, when she was younger and would use those medications, she would get overly drowsy. So she didn't think it was right for her because it affected her ability to participate in school and things like that. So what do we do for this? So what is this high muscle tone that we're talking about? So when you have an injury to the brain, you can have what's called upper motor neuron syndrome. So this is a fancy term that talks about the high muscle tone and the weakness that comes along with brain injury. So this is one of the quintessential features of cerebral palsy. And kiddos or adults who have GMFCS4-5 CP, meaning that they're non-ambulatory, often have had more extensive injuries to their brain. And that's part of the reason why their tone is more severe and more parts of their body are affected. So the key things here that we're focusing on, where you can see with my mouse cursor here, is spasticity, which is one of the most predominant types of high tone that we see in CP, and then dystonia, which is also here called as co-contraction. So why does this matter? If you're not uncomfortable, you're not in pain, but you have tight muscles, why do I have to do anything about it? Why do I, as a peds rehab doc, spend every day with my patients giving out like oral medications and injections and things like that to control it? Well, if you don't control the high muscle tone, then you can end up with contractures both in your arms and in your legs. You can end up with neuromuscular scoliosis, which not only puts a curve in your back and can cause pain, but at some point, if the curve gets significant enough, it can actually affect how your lungs are functioning. You can have hip displacement because the muscles are actually pulling your hip socket out of the joint. And then you can have Modi torsion, which is going to affect how you're actually walking in your gait pattern. Some of you might have heard of the term femoral anteversion and tibial torsion. Those are the fancy terms for how the bones are rotating because of the increased muscle tone on the bones. And this is where our orthopedic colleagues get involved. So let's break down spasticity and dystonia just a little bit. So spasticity is that tightness in the muscle that's sort of always there because the muscle has abnormal signals coming from the brain. So it's always in this heightened state of wanting to react. Almost think of it as like a flight or fight state, right? Like it gets the tiniest amount of stimulation and it's going to tighten up because it wants to protect the bones. And when you're in the clinical, when you're in clinic with the docs, when we're moving your arm around, if we move your arm slowly, we might notice that there's tightness, in your biceps or your arm. But if we move quickly, we notice that muscle bounce almost like a rubber band. So that's what spasticity is. Then there's also dystonia. So dystonia is different from spasticity because it can come and go. It's a lot more variable. And it also involves the muscles actually contracting. So when you have dystonia, the muscles are actually squeezing. It's not just how reactive the muscle is. So you have muscles that are opposing each other, firing at the same time, or it's just like a sustained contraction of one muscle. So you end up getting stuck into postures, and sometimes it's almost like a torsion or a twisting posture. So some of the two really common types of dystonic posturing that we see in CP is your arms flexing in and your wrists flexing in. And then also in your legs, you can get the feet pointing down and the knees extending. And then sometimes also with the scissoring. So you can think of examples where you might not see that, but then if you suddenly slam the door shut and that surprises a kid who has dystonia, you'll see that posturing come in and then they'll calm down and relax out of it. Or maybe they have something like a bladder infection or a sinus infection, and that's just upsetting the whole system and you'll see dystonia get worse. So classically, we think of dystonia happening because of an injury to the basal ganglia, a deep structure in the brain. But there's some new studies that are showing that one of the big circuits that goes around in the brain that goes from the basal ganglia to the thalamus and the cortex and back, what I'm circling here, if there's injury anywhere along this path, sometimes we think we can see dystonia as well. So now we have this problem. We have this 23-year-old female, right, who's got increased muscle tone, and now it's getting in the way of her life. And oral medications didn't really do anything for her. And I'm not certain if she had ever tried any injections like botulinum toxin A injections or Botox or Dysport. So the research in this area on tone management, particularly neurosurgical tone, a lot of neurosurgical tone management is really focused on the ambulatory population. And a lot of that is because one of the key goals of tone management was to keep kids walking. So if the outcome measure of the study is walking and your kid can't walk to begin with, then they get disqualified from the studies. And then on top of that, as I mentioned, a lot of individuals who fall into the GMFCS 4 and 5 category had more extensive brain injuries. And that usually means that they had a lot more medical complications that were going on early in their life as well. So having those other medical complications sometimes excluded them from studies because they wanted to keep the study from having variables that they can't account for. Because if they're seeing changes in walking and it has nothing to do with tone and it actually has something to do with your scoliosis, then you might get excluded from the study. And then I think what's probably most important is as medical care is exponentially getting better, individuals with more complicated conditions, such as those who have GMFCS 4 and 5 CP, are living longer and longer. And back when a lot of this research was being done, kids born in those generations were not living very long. So they weren't even having a chance to participate in the research. But now individuals who fit into the 4 and 5 category are living well into adulthood and sometimes even late adulthood. And hopefully we have some who fit in that category even participating in this webinar, which would just be taking it full circle as far as how far care has gone. So what do I, as the physician, do in this case to improve quality of life and reduce caregiver burden? because there's not a lot of direct data that's telling me exactly what to do for the 4 and 5 population. What I'm doing is I'm taking data on these interventions that really was intended for other populations and trying to make my best guess, looking at you as the patient and your whole history and your story, your family situation, and saying, okay, what makes sense? Let's try it. And we're making team decisions, right? The patient, the parents, and me. But it would be really nice to have some clear, clean-cut data to back us in these decisions. So right now, when you have severe muscle tone that's not controlled well enough by oral medications or injections, our standard of care is intrathecal baclofen in this population. So the most common pump that we use is the Medtronic Synchromed 2. If you look at the US pediatric ITB network, almost every center is using this. There is another pump called the Fluonix pump that does exist, but it's pretty rarely used in children and typically not used with baclofen. So if we think your child is a good candidate for having intrathecal baclofen, then a couple of decisions have to be made pre-op. We have to decide how big that medicine reservoir needs to be. And we also need to decide where the catheter tip should be placed. So when we're doing this, we're delivering medicine, the baclofen, directly around the spinal cord in the intrathecal space. So what a surgeon does is they take a catheter or a very thin tube and they insert it into the area right around the spinal cord, the intrathecal space. And then as you can see in this picture, they thread the catheter out into your abdomen and then they insert in this pump. So the Medtronic pump has a reservoir that holds the medicine. And then it has a motor that's constantly giving a certain amount of that medicine directly to your spinal cord. So this allows baclofen to get to much higher concentrations directly around the spinal cord where we want it to be, as opposed to taking it by mouth and having some of the side effects that you guys might be aware of, like sleepiness, urinary retention, constipation, and so forth. So when they're placing this, that we have to decide where to place that catheter, because if only your legs are involved, we often will place it in the thoracic or chest region because it has a tendency with gravity to go down. So that'll really break the muscle tone in the legs. But say your arms are also involved, then we might think about doing it in the cervical region or your neck. And in some cases, in very rare cases, we can even do it intraventricularly, which means that the catheter is inserted in the fluid spaces in the brain. Now, once the catheter is in, then it's up to the rehab docs. In some cases, it might be a pediatric neurologist or child neurologist, depending on where you are, managing the dosing of the baclofen. And that's really variable. There's different strategies that we can use of giving the same amount all the time or giving boluses throughout the day. And we know that individuals who are spastic tend to need less baclofen than those who are dystonic. So there's a lot of variability there too. And once you have this, you're having to come into clinic regularly to have this reservoir access with a needle. So it's not as invasive as a surgery, but it's still invasive to a child because anytime there's a needle stick involved, you know, it's something that's anxiety provoking and it's painful. But we get a lot of benefit from it, which is why we stick with this plan. But you need to have the medicine refilled at least every 6 months. But some of these kids who have bad dystonia and have high doses of baclofen are coming in even as high as every 5 weeks sometimes. Now, the pump itself has a battery. That's how the motor is going. And the battery right now is not rechargeable. So depending on how hard it's working, it'll have to be replaced every 5 to 7 years, depending on the individual. So again, if this is working for you, you would have to have repeat surgeries later on to keep it going. So what are the alternatives? Because at least for me, there's, you know, I've seen some really good responses to pumps. I've seen some not so good responses to pumps, but I was really curious, is there something else that we can be doing? And that's something else that really popped to mind for me was rhizotomy. So some of you are probably familiar with selective dorsal rhizotomy, especially if you attended Paul's webinar back in the summer talking about using selective dorsal rhizotomy versus Botox in children to decide which is a better approach for children who are ambulatory with CP. So briefly, with rhizotomy, what we're doing is, not me, but a surgeon, is performing a laminectomy, meaning that they are either taking one or multiple levels of the backbone that's covering the spinal cord and taking it off. And then they're pulling apart the different rootlets that are coming out of the spinal cord. So they're not actually touching the spinal cord, but they're getting the nerve roots that are coming out of the spinal cord. And then they separate it so they know exactly which part of the body each different level is going to. And then they separate the front from the back nerves. So the back nerves are called dorsal, so it's closer towards your back. And those control your sensation, how you feel things in the environment. And it's abnormal signals in these rootlets that cause spasticity. So they can go in and they can use a small electrical stimulation to figure out exactly what part of that sensory root is causing the abnormal signal, causing your muscle to be tight, and then they can go cut those. So depending on the surgeon and depending on your situation and what you see with the neurophysiologist who's in the operating room checking how your nerves are responding, we can cut anywhere from 20% to, in some cases, even 100% of the sensory nerve roots. Now, in individuals who have dystonia, we also have the option of cutting some of the ventral roots or the front half of those roots. The ventral roots contain the motor nerves, meaning that's what causes your muscles to squeeze. So again, dystonia is different from spasticity because spasticity is just how the muscle is reacting to the environment versus dystonia is actual contractions of the muscles. The muscle is actually squeezing when you're having dystonia. So in this case, you can cut a certain percentage of the motor roots, which will cause you to be weaker in those muscles, but in turn would also control the dystonia. So there's some situations where the dystonia might be causing more trouble than it is, like that the disturbance from the dystonia could be so bad that you're willing to give up some of your strength. So that's one of the things that we're taking into account here. So most of the literature in this group was, again, and rhizotomy was done in the ambulatory population, but recently we've been diving back into the 4 and 5 population, and there's been some data to really show that there's some promise here. So this group out of the UK did a case series of 54 children who had GMFCS4 and 5 CP, and they had specifically spasticity. They did not have much dystonia. But what they found was that there was a significant decrease in their muscle tone in their lower extremities, which was to be expected because they cut the nerve roots that were going to the legs. But surprisingly, they also found a decrease in the spasticity of the muscles in their arms. When we do this, when we do a rhizotomy, we typically are only cutting the nerves in the low back or the lumbar region. So it was very surprising that this group saw changes in the arms, because typically when kids who are walking, who might also have tightness in their arms, have a rhizotomy, we tell them that we don't expect there to be much change in their arms. But this data is showing, at least in the non-ambulatory population, there is a decrease and it's significant. So it makes you think that there's more to the surgery than we understand. And further, they found that individuals who had the surgery done had better urinary continence. So those kids who are cognitively aware were able to actually control their bladders better after having rhizotomy. And there were a handful of kids, I believe it was 4 or 5 children, who had had pumps first, but then asked to have an explant of the pump and then had rhizotomy done. And I should say selective dorsal rhizotomy. And these kiddos actually felt that they had better responses to the rhizotomy than they did to the ITB. Now, there's some selection bias there because these are families and children who chose to switch from ITB to rhizotomy. So there's a little bit of bias there. But at the same time, it is good to note that there was an improvement in just the physical exam findings as well. There was improved range of motion, and then caregivers reported that there was improved range of motion and ease of nursing care. Then Christy Bjornson, who's a PT PhD researcher who works very closely with CPRN and is actually partnered with Paul Gross on the rhizotomy versus Botox study, the first study that has been proposed over the summer or discussed over the summer. And she had done some preliminary work back in 2002 looking at selective dorsal rhizotomy in the GMFCS4/5 population. And one of their key findings, this is a group of 31 kids, right? And majority of them are GMFCS4, some of them are GMFCS5, but they had significant point gains on the gross motor function measure, specifically in sitting, crawling, and kneeling. a lot of these studies on rhizotomy were really looking at walking, right? But for someone who can't walk, increasing your sitting balance and your sitting tolerance is massive in what you're able to do. It also means that maybe you don't need to be in an ultra supportive wheelchair with like a custom molded back. Maybe you can be in something simpler. Maybe this means that you can actually, get out of your chair and be in a regular dining table and be at the dining table with your family. Little things like that that really make a difference in your quality of life. And then crawling and kneeling, huge for navigating your environment at home. Also allows you to get between surfaces of different levels, from the floor to a countertop and so forth. And then finally, a group out of 6 kids in Toronto, led by George Ibrahim, who is a surgeon scientist, neurosurgeon scientist, who's also involved with CPRN, did a systematic review looking at rhizotomy and ITB. So this was rhizotomy of all kinds, selective dorsal rhizotomy, as well as what's typically called a palliative rhizotomy, meaning a rhizotomy being done not for the sake of saving walking, but for other gains such as pain and function. And they found that both rhizotomy and ITB were both efficacious, meaning that they both worked to control muscle tone. But when they reviewed the papers that have already been done on this, they felt that there were more complications after intrathecal baclofen than there were after rhizotomy. And looking at current literature, there wasn't enough evidence to say that one was better than the other. So clearly there's a huge need here. So pros and cons of ITB versus rhizotomy. So very quickly here, because I know I'm getting a little behind on my timeline, is that ITB can be titrated, it's reversible, intrathecal baclofen can manage both spasticity and dystonia, and we can target the arms and the legs. But at the same time, you have hardware in the body, so you run the risk of malfunction and infection, and with malfunction comes the risk of withdrawal and overdose, and you're also having to have frequent refills and also to have replacements of the pump itself. Meanwhile, a rhizotomy is a one-time intervention. There's no retained hardware. You can be selective with what you're cutting. And overall, the lifetime cost is lower because it's one surgical intervention. However, it's not reversible, so there's no going back. If you only cut dorsal roots, you run the risk of unmasking dystonia. And in theory, it doesn't have as much benefit for the upper extremities, although now there's this case series that's showing that there is. So my primary research question is to ask, which children with GMFCS4-5 CP would benefit from rhizotomy over ITB? And I theorize that we will be able to pick out a subset of children that benefit from rhizotomy over ITB, and that we'll be able to figure out what key characteristics about these children allows us to know that they would benefit. So why does this matter? So this is a lot of what Paul was talking about earlier with Research CP. That this allows us to tailor care to our patients. We can improve functional outcomes and decrease caregiver burden. There can be significant cost savings, especially in some of these cases where patients had ITB and then had rhizotomy after. And just like we were talking about before, that's me as a wee resident. It feels ages ago, but I guess that's only 3 years ago. That's what COVID does, I guess. But that's me there as a resident participating in Research CP. And one of our key things is to figure out what an intervention actually makes a functional change, like what's the outcome that we want. So the study I'm proposing that I've partnered with a few others on that I'll introduce at the end is a practice-based evidence study. So it's a large observational study that will be multi-site through CPRN, where we will essentially gather a lot of data about an individual child. So we will know things like their age and sex and so forth, what we find on their physical exam. And then we will also, like the children will be, if a physician is choosing them to have ITB or rhizotomy, then they can be enrolled in the study, but we're not dictating whether they get one or the other. But we'll be paying attention to the details of that surgery. And we'll also be paying attention to their imaging. What do we see on their imaging? Is there something that we can learn from that will help guide us in which one we'd have a better outcome from? So we'll take all of that and then we'll have the children participate in these outcome measures. So some of it is really simple, like range of motion and modified Ashworth scale to measure spasticity. So that's part of a regular clinic visit. But then we'll also be looking at patient-reported outcomes with CP Child. So that'll include a lot of questions about pain and participation, which I think is really, really important in all of this. And then we will also have things like the GMFM, which will really tell how much functional change there was, such as sitting, balance, and crawling, and so forth. So the first aim of a preliminary study that I submitted, I forgot to mention that we came up with the lovely acronym of SNAC, which I felt was very applicable to children. We're cut for surgical non-ambulatory children with CP, so SNAC. So the preliminary SNAC study will include a aim where we're actually looking at practice variation, just like Paul's other study was, of how we select children for these interventions and how we actually do the surgical technique for ITB and rhizotomy. And this already has 2 different internal grants, one through the Department of Physical Medicine Rehabilitation and the other through Baylor College of Medicine as pilot funding. So this is already getting ready to get started in the next month or so. And then the second aim will be to actually figure out what outcome measures should we be using, because I want to know what outcomes actually matter to you as a patient, as a family member, as a caregiver, what actually makes the difference. And so I'm hoping to put together a group of clinicians, patients, and caregivers so that we can really go through what outcomes matter and then look at what outcome measures are available and figure out which ones we should be using that are validated so that we can use them in a scientific way. So I have partnered along with Jeffrey Raskin, who's a pediatric neurosurgeon at Riley Children's Hospital that's affiliated with Indiana University, and George Ibrahim, who is also a pediatric neurosurgeon as well as a surgeon scientist out of Sick Kids. Jeffrey does a lot of rhizotomies, and this is definitely one of his areas of expertise. And then and he also does it in the non-ambulatory population. And George does rhizotomies in the ambulatory population, but also does a lot of work on connectomics and looking at neuroimaging so that we can understand how brains are wired differently and how that might give us a clue into how to decide what intervention we should be using. So with that, I will take any questions you might have, and I'll get out of screen sharing so that we can ask questions.
That was great, Shruti. Thank you so much for taking the time to prepare that and really speaking at a level that is really very easy to digest. So I really appreciate that. So I'm going to offer to people that they can, I don't remember if I've got hand raising as a capability. So I don't think we have that on this implementation. So I'm going to let somebody unmute if you want to unmute and ask your question, or you can type it into the chat and go from there. And so anybody have a question for Dr. Thomas?
I do.
Fire away.
Hi, this is Amber Gorman. My question is, how do you definitively clinically identify dystonia? Because I've heard so many different variations where spasticity is velocity dependent by definition, although, you know, that can get muddy depending on who's defining it as well. So I'd be interested in clarification on that. And then my other comment is with dystonia, if it's squeezing of the muscles and you're cutting the ventral nerves also control motor movement. So how is that different? Like, because to me, squeezing of muscles is different than voluntary movement of muscles. I'm not quite sure if I'm asking my question clearly, but I hope you understand what I'm saying. If not, please clarify.
Yeah, thank you so much for those questions, Amber. So to start, picking out dystonia can be tricky. So, you know, essentially dystonia, one of the key features is that it can come and go. And there are some standardized measures like the HAT, which some of my other colleagues in CPRN have talked to better than I do because it's what they study all day. But essentially what it's trying to get you to do is to distract you or do other tasks to see that when you're focusing on the other thing, if the dystonia comes out. Because oftentimes what you'll see with someone who has dystonia, if you tell the kid to, you know, just be tapping their fingers like this, right? that'll be distracting them. And then suddenly you'll see their legs start to stretch out, or you'll see their toes point, or their legs scissor. So that's a sign of having dystonia. So there's a whole collection of tricks like that to pull it out. And then there's some newer techniques where we actually videotape individual who we suspect dystonia in, and we have them do a whole gamut of movements like that. And then we actually go back and watch it to look for these little things that might be coming out. Like sometimes if I see a kid walking in the hallway, they might be an ambulatory kid with CP and their arms are moving normally. And then I ask them to pick up the pace, and then you'll see one of their arms start to come up and flex. And that's a sign of dystonia. So there's little things like that, but it is tricky because if you have someone who is really, really tight and spastic, they might not have enough movement to pick out that there's also dystonia. And until you block that spasticity, you might never know that there was dystonia underneath it. And I think that's where it gets really, really tricky when you're making some of these surgical decisions, and why after the original studies in the 80s and 90s, they really went away from doing rhizotomy in kiddos who are 4 and 5 on the GMFCS scale, because they usually had such high muscle tone, we didn't really know if there was dystonia. Now, the other question that you asked, remind me, about dystonia was about the muscle contractions and when you cut the motor nerves, correct?
Yes, the ventral nerves versus the dorsal.
So we know that dystonia is being controlled by a part of the brain called the basal ganglia. And that signal pathway goes through to those motor nerves, which then tell your muscle to squeeze. So that is part of voluntary muscle movement. Now, if you have a disruption in that pathway on how the basal ganglia is working, it doesn't coordinate right. It doesn't work together with the other muscles. And that's why you get them firing all haywire, and one might be firing when it shouldn't be firing, or multiple are firing at the same time. However, it usually comes out when you're actually trying to move your muscles. So that's what's so tricky with dystonia, because if you want to control it, then you actually have to weaken the muscle, because it's the same nerves that are giving you strength are also the same nerves that cause dystonia to happen. So when you're doing it at the level of a rhizotomy, meaning the nerve root that's coming out of the spinal cord, we're not able to split the control versus the strength, which is, if there might be some future technique down the road, especially if there's something we can find within the brain itself, maybe you can separate those two pathways, but right now we can't.
So it's going to cause more weakness then, correct?
It is. So I can tell you, in some of the children I've taken care of that have chosen to go through with a rhizotomy, knowing that they were going to have to cut some of the ventral roots, they were having such significant pain and they were risking having a hip dislocation. So they made the decision that it was worth giving up some of the spontaneous movement that she had to get the pain control. And what's really interesting is, so for this particular patient, she had had a pump and it just didn't work well for her. So she wanted it explanted, but she loved to swim, because when she was in the pool, even though she was weak, she was able to kick her legs and she really loved that sensation. So they were very worried. Mom and dad were very worried that losing that might be a big deal, because they were like, well, we can have her in the pool with like more floats and more supports, but it's not going to be the same as her kicking. But after she had the rhizotomy, we did cut 50% of her motor roots, but she's still able to kick in the pool today. So it's not perfectly predictive either. So we have some kids where they're so weak underneath that you risk there not being much movement, and then other times we still see movement.
So there, in theory, there would be more.
Amber, we have a couple other questions. So
Okay, sorry.
we can come back if there's time at the end, and
That's fine.
We might have extra time. And I did want to add that we've run a parallel process to Research CP called Research CP Dystonia Edition. And that's got a number of sort of world leaders on dystonia involved in it. And what's coming out of that is a fair amount of focus on improving diagnosis for dystonia. So I think you'll see some good work there. So I'd recommend you keep track. We'll put it up on MyCP webinar series when the time is appropriate. So the next question for you is from Christy Bjornson, who said, thanks, Ruthie. How will you query patients and families about outcomes for the project?
Yeah, so what we were hoping to do is actually start off with a Delphi study. And we were actually hoping to partner in the future with either MyCP or other organizations like that. where we would be able to gather individuals who have GMFCS4/5 CP, as well as their family and caregivers, and then clinicians who care for those individuals to really talk through what outcomes we think are important. You can see on the previous slides that there's some that we've brainstormed as a physician team that we think would be important, but we're sure there's things that we're not thinking about that are actually going to be important to each individual. So we're hoping that once we know what those outcomes are that are of importance, that we can then take a look at all the outcome measures that exist that are validated and try to pick the ones that actually are tailored to those findings.
Great. And so I would definitely support you doing that through MyCP and other organizations as well. But we'd love to get some of that discussion going on the forum so it can get captured. Okay, the next question is from Connie, who asks, how do you decide about selective dorsal rhizotomy versus selective ventral rhizotomy versus selective dorsal ventral rhizotomy?
Yes, thank you. So, so selective dorsal rhizotomy, I think, is probably the easiest to decide on in some ways, if you have a child where you're really convinced that it's all just spasticity. If you really think that it's purely spastic, or maybe they have a long enough history that you've seen them where they're more mobile and it was still all spasticity, and then as they've become more progressive with their tone as they've grown and their muscles have stretched, in those cases, we will say selective dorsal rhizotomy, and we don't have to worry about weakening them by doing the ventrals. So a selective dorsal rhizotomy is selective because when the surgeon is in the operating room, they're breaking those roots that are coming out of the spinal cord. They're actually teasing it apart. It's not breaking it, but teasing it apart into little rootlets. So it's almost like making a single strand of spaghetti into little strands of spaghetti. And then they're stimulating it with electrical current and trying to find which one is causing the abnormal signal. And then they cut those. That's why it's called selective, as opposed to non-selective. So typically when we're doing ventral, we're not able to get as fine a control or a response. So if we cut ventrals, most neurosurgeons are choosing to just cut 50%, and it's a blind 50%. Because in the OR, if you stimulate any of them, you're just going to get the muscles to contract. There's not usually one that's more powerful than the other, based off of some surgical literature. And then if you're doing a selective dorsal ventral, so that in itself is a question in itself. So some of you have probably heard the term palliative rhizotomy. Palliative, I think Ed Hurwitz, the chair from Michigan, who's also part of the CPRN exec board, had previously in a different talk brought up that, some people don't like the language of calling it a palliative rhizotomy because it sounds like, there's no hope there. But the true definition of palliative is that you're making things better. And so that term palliative rhizotomy got applied to any children who are having rhizotomy where the hope was not to maintain walking. So that was the original. And the classic palliative rhizotomy did not use neurophys monitoring because they were like, oh, we'll just cut whatever percentage. And typically it was cutting all of the sensory roots that you would get rid of all of the spasticity. And oftentimes they were cutting 50% of the ventral roots as well. So what people define as a palliative rhizotomy is highly variable. And that's actually why I'm doing the practice variation study, so that we can really tell them apart. But when we choose to do it is when we think that there's significant dystonia, because our concern is that if you get rid of the spasticity, which is getting in the way of the muscles actually firing and squeezing, that you can make dystonia worse, because now the spasticity in some ways is blocking some of the dystonia.
Great. Ellen, I should have been asking all the way along. Would you like to ask your question, or do you want me to ask it? I'll give a moment. Okay, I'll ask. So down the line, could this lead to studies for adults with spasticity, particularly if you've not received a treatment for spasticity before?
Yes, I would be very hopeful of that. And I should say that I am biased in favor of it, because a lot of my questioning of this type of intervention came from my last couple of years of training at Colorado, where we had multiple individuals who fit that GMFCS4/5 category who had mixed spastic dystonic CP, and a couple of them were adults, or young adults. I think one was 19. And we had great results when we did it in her case. And we had a lot of discussions about it. The neurosurgeons went back and forth about how safe they thought it was, and the results were incredible, and that patient was super thankful. So I think there's definitely room for considering it, because oftentimes we don't talk about rhizotomy in older individuals because we're talking about walking. And we know that there's that crucial period in young childhood where if you get rid of that muscle tone, you can retrain a child to walk with like a more classic walking pattern, which will put less pressure on the joints and the bones, and it'll allow you to stay walking for longer. And that's why we never thought about doing it in older kids, because you don't get as nice a result because your brain is wired to walk the way it was learning to walk the whole time. But in this case, if we're not dealing with walking, it does raise the question, why are we not considering this in older individuals and adults? So I would say absolutely that is one of the areas I would want to be pursuing once we have more information in the population that we're doing it classically in.
Great. Couple other, so there's some compliments. Christy likes the Delphi approach and thinks you should use MyCP, as do I, but I also think you should get all the feedback you can and build a group of people to help you. I think it's one of the great things we can all do together. I have a question for you. Do you have a sense yet for your observational comparative effectiveness study? Have you gotten to the point where you have any idea how many kids you might be trying to enroll, or are you not at that stage yet?
Yeah, no, we've been talking about that and looking at the variations. I think realistically, we're probably going to need about 100 rhizotomies to get enough data for the surgical variation that goes into rhizotomy. And if we're looking at that, then obviously we would need at least an even matched number of pumps, but pumps I think are frequent enough. That's less of a concern. So I'm guessing that we would probably end up with 100 to 200 pumps plus about 100 rhizotomies is what we would hope, and rhizotomies of all kind.
And will there be any looking at kids that are getting medical interventions, or not in the study design as you see it?
Not in the study design right now, only because it's hard to pick out those children. We would essentially need to have children that went to their specific tone management clinic where they decide on surgeries and know that they had made the decision not to go forward with the surgery. Okay. So I think, if we do that at individual institutions, it might be possible to embed in a smaller subset. Because like if you take Texas Children's, like I would know all the kids going through that clinic and I would know who we suggested what to and if they did or didn't do it. But then to have that type of fine detail at a lot of sites might be difficult. So I would imagine that we might be able to have a small subset, but I'm not sure if we'd be able to have it be like a full part of the study.
Great. Let me just check before we wrap up. If anybody else has questions, you can either unmute and ask your question or type it into the chat. Well, let me say next month we have Dr. Bhuma Ravanamuthan talking about family attitudes towards CP diagnoses. There's an open survey on MyCP that parents and caregivers of children are encouraged to fill out. We've already fulfilled all the sort of adult the adult responses that we want for that. So keep an eye out for that. There will be mail and invitations to that. But let me just thank you, Shruti, so much. I think that I was really very struck by how complex the topic was and how well you conveyed it. I really valued it. And I think from the comments, it looks like many, many people did. So thank you very much and really appreciate it. And good luck on your study.
Yes, absolutely. And I'll be in touch with more details.
Okay.
Yeah.
Thank you. We'll have you back. That's for sure.
Yep.
All right.
My pleasure.
Good night, everyone.